My name is Deanne Pelletier. I'm the Director of Annual Giving here at the Trust. I am pleased to welcome you to What's Up Doc, a monthly lecture program brought to you by Concord Hospital Trust. Concord Hospital Trust would like to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up Doc. The Walker Lecture Series offers a wide variety of programs on history, art, and science, as well as dramatic, musical, and literary performances. All events are free, open to the public, and held at the Concord City Auditorium. What's Up Doc is proud to welcome Dr. Angela Yerdon McLeod today. She graciously agreed to step in for us at the last minute, so thank you. She received her medical degree from the New York College of Osteopathic Medicine in 2001. Following her residency at New Hampshire Dartmouth Family Medicine Residence, right here, she completed a fellowship in women's health at East Carolina University in Greenville, North Carolina. She then returned to the residency program here at Concord Hospital to join the faculty in 2005 as the maternal child health education leader. She is board certified in family medicine. She is an active board member of the New Hampshire Academy of Family Physicians and an advocate for opportunities in leadership advancement, particularly for residents and for those underrepresented in medicine at the national level. Her clinical and research interests include family-centered maternity and neonatal care, breastfeeding medicine, neonatal withdrawal syndromes, contraception management, and postpartum mood disorders. Angela leads the Concord Hospital Achieve Wellness Council and the New Hampshire Medical Society's Physician Health Committee. When she is not catching babies or teaching about them, she can be found nurturing the well-being of her peers, her family, or herself. She can be found hiking, kayaking, mountain biking, or skiing in the New Hampshire or Maine mountains. Please join me in welcoming Dr. McLeod.
Thank you. Hope I can entertain you and tell you a little bit about what's happening here in our hospital with babies and babies that might be going through withdrawal syndrome. And also tell you what's happening in New Hampshire and our community. I'm actually taking care of babies right now, and this is the middle of my work day, so I just paused and ran over here, and I have to go back up to our family place nursery just after this. So I've actually been working to get here in front of you, members of the community, to teach you a little bit about our babies and families that undergo neonatal withdrawal syndrome since I was 13 years old. When I was 13, one of my teachers of biology asked us to find an article that we were interested in learning something about. And the thing that drew my attention was a Newsweek article that was titled Crack Babies. And some of you might remember this, like early 90s, where women were using crack cocaine, and this was very detrimental to their health and their babies, and I knew nothing about pregnancy. I was 13 and in 8th grade, but I found it very intriguing, and that pretty much started my journey to get here today to be a teacher of medical students, residents, other physicians, and families, and to our Concord and New Hampshire greater community residents too, my job as a residency educator. So I'm going to tell you a little bit about what I do and what's happening around the state. A few months ago, I had a couple of cases just on a usual day. One end of our family place, I had a patient named Jessica, these are not their real names, of course, and this is not a real picture of my patient. But I had a patient on one end of the floor, that was Jessica. The other end was Rachel. Jessica had come in and really wanted to breastfeed her baby. She didn't tell anybody that she was using cocaine. The other patient on the other end of the floor, Rachel, really wanted to become a nurse, and so she had a problem with substance use disorder, and she was using buprenorphine, which is Suboxone, and she had previously been addicted to morphine or fentanyl and had gotten into a treatment program, which was the ideal situation. But when COVID happened, she lost her transportation and she couldn't make it to that treatment center. So she was getting that off the street so that she could maintain her sobriety. And then she became pregnant. So she continued to use that medication, but she didn't want anyone to know that she was using that, so she never told anyone throughout her pregnancy. So when I went in to go see both of them at different times and see their baby, it came up that their urine drug screening was positive, and I had to have a conversation with them. At that time, it was very late in the course of their prenatal care, and both of them were feeling scared that they were in trouble, that they might lose their baby to the state, to DCYF, and we had to have very difficult conversations. I also use this as an example of the culturally diverse patients that I take care of. We have a very supportive community at the Family Health Center that takes care of refugee population. And I often do take care of patients that are of various backgrounds. And right now, we have a group of patients that are coming in from Afghanistan and also from Ukraine. And so we have, although this is not one of the patients who I was describing the case to you, I do wanted to share that we care for families of all descriptions and various backgrounds, and that gives a lot of variety and depth to the care that we do provide here in Concord. So this presentation is a little bit medical, so I hope that I'm going to try to make sure that you understand everything, but I want to talk about what is the current state of neonatal withdrawal syndrome, which is babies going through withdrawal after they've been exposed to substances, and what's happening currently around our community. That's the first thing that I'm going to talk about today. So the current language that we use is substance use disorders. That's the recommended verbiage, and instead of saying addicted, we say substance use disorders. And this is when people recurrently use alcohol or drugs that cause a clinically significant impairment, which impacts their health or leads them to have a disability so that they can't meet the things that they want to do in life at home, go to work, go to school, and leads to difficulties. The reason that I want to give you that definition is because babies don't have a substance use disorder. They don't go around searching for drugs. They actually are just born in a state where they have been used to having the substance provided to them through their mother, and when the mother was pregnant. And there could be a whole variety of why that baby was exposed to that substance. It might not be just because the mother was using substances off the street or be having a substance use disorder. It might be that she was actually prescribed this medication for a medical condition, like pain. Maybe she had kidney stones throughout her pregnancy and had to take a medication. The baby ends up being born in the same situation and can go through withdrawal. And so if we know that a mother has been using a medication, then the baby ends up having this state that we have to care for them in the same manner. And so it's important to know ahead of time what we're looking for to be able to treat the baby in the best way possible. It's also recommended that mothers who have been using substances such as fentanyl or morphine, that they are maintained on a medication in a program or an assisted way so that they have a stable, steady state, and that they're not going on and off and on and off. They have a higher risk for their baby or for themselves. And so if we can get them into a treatment program, then we know that they are going to be stable, their baby will be stable, but we know and anticipate that their baby may go through withdrawal symptoms at the time of birth. This is the current state of the country. This is the most recent data that I have regarding opiate use disorder. So this is not particularly related to all drugs in general, but this is specific to opiates, which is like morphine, fentanyl, heroin, or prescription opiates. On this map, we don't have New Hampshire because New Hampshire didn't provide data into the source. But you can see the dark blue areas are the states that have the highest situations where rates of neonatal abstinence syndrome or babies being born substance exposed are. And nationally, it's 6.3 out of 1,000 births. That's on average. And there are 5 states that had over 20 babies born out of 1,000. And these are the highest states here. Let's see if I can use a pointer. So UNH actually did a similar study, and they came up with New Hampshire's data, so we can kind of extrapolate where New Hampshire would fall. And so the 5 highest states were West Virginia, Maine, Vermont, Delaware, and Kentucky. And as you know, New Hampshire falls in between Maine and Vermont on a map, and we were at 24.4. So 24.4 out of 1,000 births are babies that are being diagnosed with neonatal abstinence syndrome, which is specific to withdrawal from opiates. So we're right here and would be in a dark blue color. So that's just kind of giving you that. UNH also provided data. This is a little bit older, but this map on the over here is the number of adult deaths from drug overdoses in New Hampshire over the past about decade, 20 years, 95 to 2016. And you can just see how this has increased. And I know that you know this because if you watch the news, you can hear about how many deaths there has been from opiates. And I'm sure that you probably have heard of somebody, a neighbor, a son or daughter of somebody that you know. And right here, it has just grown up and up and up. And the orange line is males, the purple line is females. This sharp incline matches the number over here of babies that have been born and also exposed to opiates and have gone through neonatal withdrawal syndrome. So here's the kind of like increase, and this is from 2000, so right about here. And then that just has gone up and up and up. So this is what we have been experiencing here in the hospital. My work that I do is that we're just seeing more and more babies coming in the hospital and being exposed to these substances, and then we have to take care of them and their families. So this is the most striking thing that I can tell you today, is that substance use is the leading cause of maternal mortality in New Hampshire today. So when you think about, like, why do women in the year around pregnancy, from the time they're pregnant until the 1 year postpartum after they've had their baby, die? Most people think of they might have a hemorrhage during the birth, right? Or postpartum, they have preeclampsia or toxemia of pregnancy, as it used to be called, or a blood clot or something like that. Like that might be what women around pregnancy time frame die from. It's not that. It is substance use disorder. So we have to do something about this. And it's specific to the babies from that graph that you saw in the 10 years over the last decade, the number of infants diagnosed with neonatal withdrawal syndromes increased 5 times. In New Hampshire, it went from 52 to 269, and it's only gone up higher since then. The number of days that babies have to stay in the hospital depends on how long their withdrawal symptoms go for, and the normal newborn course, like if everything's going well, they don't have any infections or jaundice or any other complications, they usually go home in 2 to 3 days. That's the average normal course. But babies who are experiencing withdrawal symptoms, the average number of days is 12. So it's a lot longer stay that leads to a lot higher cost, and nursing staff, which you may have heard we're having a hard time with having enough clinical staff to take care of all of our patients. So that just has caused a lot more distress on everybody, and their families too. Like, they don't want to be staying in the hospital. They have other children, jobs to go to, life to get back to. So it is a big burden on everybody. And then the most recent data that we have from 2022 is that in a real number, the number of babies that are exposed but being monitored and not having actual like disease is 6% of current state, or that we have them stay for a prolonged time, and 2% are actually having symptoms and being a diagnosis of being affected. This is statewide New Hampshire data. So this is why we care so much about this, is that if it's substance use disorder is untreated, it causes maternal issues, overdose, which can lead to fetal death, loss, preterm births. The optimal care is really treating mothers throughout the pregnancy with a medication that keeps them stable, that decreases the risk of babies dying in utero or decreasing the risk of preterm births. And our management really must address the whole person, the whole family. There's a lot of coexisting mental health conditions. Often intimate partner violence is part of that, and access to health care. As I mentioned in that case, one of the problems was that the one patient lost her transportation, which ultimately caused a spiral out of control. And back into using substances from the street. So our real goal is to take care of our community. These babies are our next generation, and we want moms and babies to stay together, and the mom cares the most about the baby. I mean, we care about our babies so much, but the mom and the families care about them even more than we do. So they want that, keep their baby, and they want the best thing for their baby. And we want them to have normal childhood and development. So I've said a lot. I keep saying the word neonatal withdrawal syndrome, but I want to tell you exactly what that is and what we see in the babies. And it's really a whole constellation of symptoms that kind of all go together. And when there's a withdrawal from opiates like morphine or fentanyl, or prescription pills like Vicodin or oxycodone, then it's called neonatal NOWS, neonatal opiate withdrawal syndrome. But neonatal withdrawal syndrome may be withdrawal from any kind of substances, and sometimes there are multiple substances, like if a mother is prescribed a medication but also is a smoker, there are layers of withdrawal that the baby might be going through. But it's a problem of all of these systems of the body, the brain, the autonomic system, and the GI system. So I'm going to talk about each one of these systems real quick. So these next section of my presentation is what are the symptoms that we see in the baby. So The problem with the brain system, the central nervous system, is the brain. And what we see in the babies are babies that cry a lot. They just can't really settle down. They have problems with sleeping. Like most babies sleep for a long time, like 2 to 3 hours. They wake up and then they feed and then they go back to sleep. But these babies, they can't sleep. They stay awake and they don't sleep for more than like 1 hour time. And so it's very hard to get them to settle down. And if they're awake all the time, then they burn a lot of calories, and they're just very startled very easy. They're jittery, they're shaky, they have very high like muscle tones, or they're like very rigid. At the worst of it, they could have seizures. So that's the brain section. And then the autonomic nervous system is like the temperature regulator, like of your car. It controls all of the inner workings of your body. So fever, temperature control, sweating, yawning, nasal stuffiness, breathing, like the control of the breathings, like the control panel. So those things all get thrown off as well. And then the GI tract also, so this involves how they're feeding. So they want to suck all the time. It's a normal newborn reflex to be sucking. So because babies don't know how to suck, then they can't feed. They can't survive. So what they're sucking is over exaggerated, and so sometimes their feeding gets very discoordinated. So they're like, suck, 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 and then they start like chomping and trying to find the bottle or nipple. They're like all lost in space and they can't really figure it out. And then sometimes once that food does get in their belly, then they start vomiting, and then they have very loose stools or diarrhea. So all those calories that we're trying to get in, struggling to get in, then they end up losing because their muscles are moving all the time, or they're having diarrhea or throwing it up. So if we know that the mother is having using some substances, we can anticipate this might happen. We can do a lot of education for the family and expect it. And up to 3/4 of babies who have been exposed in utero will develop some sort of withdrawal symptoms. Most of the symptoms start on the second day. Once the umbilical cord's cut, it takes a little time for those medications to come out of their system, and most of them will peak on the 3rd day. So we keep our babies that we know are having this problem in the hospital for at least 96 hours or 4 days. And if they're doing well, then they can go home at that time. And a lot of babies do fine, and then they go home and the parents are educated on what to watch out for, and they monitor their symptoms, and they monitor the calories and make sure that they're growing fine, and they follow up with their outpatient doctor, make sure that they're gaining weight appropriately. The ones that are not doing well and they have these symptoms, then they stay longer in the hospital until they're meeting all of their goals, just like any other baby. There's some things that can make this syndrome come out even more so. So we know if there is smoking in pregnancy, if mothers have a low weight themselves, if the mom herself is on a medication called SSRI, which is like Prozac, Paxil, Zoloft, those medications for treatment of anxiety or depression, then that can worsen this situation. And some babies can have withdrawals from that medication alone. So we're aware of watching out for that medication, regardless of any of the others that can cause problems. And then the layering of multi medications makes it worse. So we have some tools to assess what's going on, to know how significant the syndrome is, and what do we do about it. So previously to 2016-17, when those graphs were pretty low, way back since 1975, actually, that's the year I was born, there was another tool called the Finnegan assessment, and that used a scoring system because in the past there was women who were pregnant who had used narcotic medication for any different, sorts of reasons, like maybe they had surgery during their pregnancy. And this was a scoring system that looked at all of those symptoms and marked up at least 27 different symptoms on a baby. Every 3 hours, the nurses go in and check. Are any of you nurses, or previous nurses? Yeah, I was hoping so. So can you imagine going and doing your vital signs and looking for 27 symptoms on a newborn? And the symptoms are like, are they yawning? Are they sneezing? And then if they were sleeping, they actually wake up the baby and then ask the parents, did they do any of these things? So then the parents are feeling like, I hope they don't do any of these things, because if they get a high enough score, then we would start them on morphine. And they got on morphine. It was a dose based on their weight, and if they were a big baby, they got a higher dose, and it would take long time to wean them down. And that's why some babies were staying in the hospital for up to 30 days or so. So that's where our long hospital stays were coming from. So that Finnegan scale was useful for initiation of medication pharmacotherapy. Over all of that time, from 1975 until now, it actually never was scientifically validated. It was just out there used in hospitals. And it's actually still one of the major methods of assessing babies that are going through opiate withdrawal. But in 2017, a new tool started coming out, and that's the Eat, Sleep, Console tool, which is what we use now here in this hospital. And that's based on non-pharmacological care at first. So I've been involved with this care ever since I was a resident, and one of my attendings was looking at a baby who was going through withdrawal symptoms based on an SSRI on Prozac. And we kept looking at this baby like, why isn't he eating? It's very sleepy. And we started looking into, the mother was taking Prozac for a very severe history of postpartum depression. And so we ended up drawing levels of the mother's blood and the baby's blood. And I actually did a whole case report on it because there wasn't very much known about that way back then. This was 20 years ago. And I wrote it up in a journal, and I ended up having it published, and I presented it at a national conference in Florida as part of my OB fellowship. And so that got me on this, way back from, every time somebody says like, oh, you want to do a presentation on this, I take the opportunity to try to educate people. So when Deanne said, do you want to present to the community? I said yes. So in 2017, we had the number of babies was so high that were experiencing withdrawal, but we were also over-treating them with medication and keeping them for a long time. And it was exhausting, and we really didn't know what we were doing, to be honest, because there hadn't been so many babies experiencing these symptoms. And there wasn't a lot of literature done on it. Like, there wasn't anything, when I was looking at SSRIs, there were like 10 case reports, which is why somebody wanted to publish what I was doing. So we were taking anything that anybody was writing and saying like, is this what we should be doing? And that's what all hospitals around the whole country were doing until there came up to be enough volume of babies that were treated. And then we started saying, I don't think this is the best way. I think we need to try something different. So a couple other pediatricians and I went to a meeting at Wentworth Douglas Hospital, and we heard about this new program called Eat, Sleep, Console. And it was based on treating all babies going through withdrawal like any other baby. Like, the goal was to treat babies as if our focus was on ensuring they were able to eat the desired amount that would make them gain enough weight, that they were able to sleep 2 to 3 hours in between feeds, and that our focus was teaching the parents on how to keep them consoled in between. So consoling is doing swaddling and skin to skin, and that the nurses were not the people to do all of that care. It's the parents. It's the parent's baby. The baby's going home with the parents. And so the nurse's job was to be the educator on how to get the parents to be the one, and actually the babies respond so much better to the parent than to the nurse or anybody else, because like they know their parents. So when you give the baby to the parent, they just settle right down. They know their voices, they know their smells. So we started coming up with our what we lovingly call our TLC bundle, our Tender Loving Care Bundle. And it involves all of these things. And the number one was keeping the babies in the room with the parents, having the parents be there as much as possible, doing soothing measures, which are the 5 S's of swaddling, sucking on a pacifier, shushing, swaying, and having them lie on their side, teaching the parents how to do swaddling themselves. So every time the baby would get unwrapped from their bundle of blanket, the parents could get them back settled down, putting them directly skin to skin, and this could be the dads too, or the grandparents, knowing when the babies were ready to eat and feed them like early and often, keeping it quiet, only interrupting them when they were awake and ready to be fed, rather than the nurses coming and going, it's time for your vitals, time to wake you up, see if you're jittery, when they weren't, and then they were. And then all these other things, limiting the visitors, teaching about safe care for making sure they weren't falling asleep with their baby, dropping their baby. And then doing the cuddler program. So we implemented our cuddler program, which you might have heard about, and also using complementary therapy, which we're fortunate to have here at this hospital. We have live music with harp coming in and playing, and Reiki therapy, both for the parents, and also they do Reiki on the baby. So I don't know if anybody has seen this on New Hampshire Chronicle. Ginny said that she has. But if you haven't, you can go online and just search New Hampshire Chronicle, The Power of Cuddling. I was going to try to show you a little clip, which would be, it's a window into our nursery, into what the volunteer cuddler program is all about. But it was really blessing at a time when we had so many babies. We taught classes to volunteers in the community to come in and hold babies and cuddle them, which allowed the nurses to do more higher level nursing care. And so the cuddlers program's still going. This got started back in 2017-18. And at one point we had a list of up to 80 people on our list to come in and cuddle. They're 2-hour, and you can still sign up for it. There's 2-hour windows, and sometimes we need somebody there for like 12 hours at a time. So
I think there's a waiting list, actually.
Is there still? But sometimes there's long hours that we need people for, because the parents might need to leave to go take care of their other kids or have an appointment, and they have to go for a full long day away. And it's very helpful for our nurses and for the babies. So I would encourage you to watch that. Breastfeeding is recommended with these babies, even if the mother is using medications. The benefits are immense, because it's the closest skin to skin that you can get. There's so many nutritional benefits to breastfeeding. And it decreases risks in the mother for ongoing chronic diseases, and also for the baby, decreasing risks of infection. There's contraindications if mothers are ongoing using illicit substances, then we don't recommend it. But if they're in a stable treatment program and we know what the medication is, then it's not any more harmful than what the baby was already exposed to in utero. It actually keeps them more stable going home, and it's also stabilizing for the mother who has a history of substance use disorder to be able to breastfeed. It actually, studies show it decreases their risk of having relapse of their drug addiction. So sometimes, even though our best efforts with all of the supportive care and TLC bundle and cuddling and all of that, Medication still might be necessary. Sometimes the withdrawal is just very strong in some babies compared to some other ones. And if we need to do medications, we start out with doing one-time single dose just to try to see if that can calm down the baby, and then we're able to better feed them, and then it might get them out of that little area that they, that day or that hour, and then they can go back and be settled again, and then that might be all that they need. So we try for that first. But if they require more than 2 times of a one-time dose, then they have to go on a scheduled dose of morphine and then get weaned off, and that's kind of back to what we used to do. And there are other medications that we use sometimes as well. So this is our actual Concord Hospital data, which you can see it kind of mirrors the New Hampshire state. From 2009 until like 2017, we had the blue is the babies that were substance exposed. These are actual birth numbers in our hospital, and the orange was the number of babies that required medication treatment with morphine to get them out of the withdrawal. At this year was when we implemented our change to the Eat, Sleep, Console, where we stopped using as much morphine. At the same time, we implemented the Cuddler program in April of 2018, and in July, the Eat, Sleep, Console program, and we went to 0 doses of morphine. We also had these other things going on long time before with Reiki and music, educating the staff about all of the neonatal abstinence syndrome and complications of it. And then the most recent data, unfortunately, the numbers have gone down and then starting to go back up a little bit, and our need for medication has increased. And I really feel it's because the after effects of COVID, as I said with that one case, the woman lost her transportation, the stresses on families you all have experienced it too. Social isolation has really caused a lot more harm than we anticipated. So hopefully we can start getting this number back down as people come back together, and instead of having a What's Up Doc on Zoom, you guys are all here and saying, oh, hi, I haven't seen you, how are you doing? It does a lot of good for everybody. So every time you do a study, the end result, if any of you are in education or medicine, the bottom line, they'll always say, this needs to be replicated in further studies. And so good for us, it was that the New England Journal of Medicine put out a across the country study looking at the Eat, Sleep, Console approach compared to the usual care, which was the other way, the Finnegan care for neonatal opiate withdrawal syndrome. And this was just published last spring. I think it was May. And so they took the study that we had done here at Concord Hospital and replicated that with over 1,300 babies, and showed that it also significantly reduced the number of days that babies were staying in the hospital. And they looked at the safety. Was it safe to do it in this manner? And was there any other babies that were getting harmed by having to come back to the hospital, going through longer withdrawal, or getting sick, or having bad outcomes by not giving them the old treatment or the morphine? And there was no difference in safety outcomes. So that is very reassuring for us to have done this, to continue to do this model too. So finally, I just want to talk about the improving care as a team, and also for the community, and the things that we're doing now that are action items. So the last part of the study that we did was we interviewed 7 families, audio recorded their conversations, and then analyzed the results. And we found that our that Eat, Sleep, Console program showed that the mother-infant attachment was even better with the new program than the old way that we had done before, and that our healthcare team really has a strong impact on how the mothers and the babies can be bonded together. And if there was a conflict with the nursing staff and the families, that could impact the bonding in a negative way. So what that means is that if the nurses and the doctor team came in and was like, you're doing a great job, you are the best care for your baby, and let me help you and teach you on how to do this, you're doing a great job, then those families felt empowered that they could do it and they could go home and they could be a great parent. So we have some like quotes that we kind of got out of that study, were that I did a lot of skin to skin with him. I was always holding him. That's very like positive. It was better than I expected. There's a lot of fear about what's going to happen when I have my baby. Is the baby going to have withdrawal? Is somebody going to judge me? And am I going to be able to go home with my baby in the end? How sick is the baby going to be? I expected the worst there was. I expected him to have actual withdrawal symptoms immediately. The nurses helped me to change him and stuff when I couldn't get up and answered my questions. Everything he did, I would ask, is that a symptom? Another one, which was a little more negative, was I felt judged by some of the nurses. It wasn't anything they said specifically, just the tone and their facial expressions. So no matter how well we try to do as healthcare staff, people come in, they're always fearful, and they're going to feel judged in this situation, because it is a very risky scenario that they're walking into. And then another one was, I knew it would be hard. She's my daughter. I love her to death, as hard as it gets with her. I wouldn't leave her for the world. I will fight through it. So also determination. That as I said, the parents love their babies so much, and they'll do anything for them, and they really want them. They really want to take them home with them. They want to do the best for them. And I see that they're really trying hard, and we are the institution as the hospital, so it's really our job to teach them and educate them. So as I said before, I just want to point out again that this is the 2021 maternal mortality kind of rates, and this was all cause of death associated with pregnancy. Overdose from fentanyl or cocaine was 4, and this was higher than any other number. The medical causes, these were all added together, which came up to 5, but that was like with one of each of these kind of things. So the highest number was from overdose. So what are we doing is that all these organizations from across the country, the CDC, perinatal collaboratives, Dartmouth has a New England collaborative called NEPQUIN, have put together, they take the data that exist and say, like, if this is the highest thing that's happening in our state that's causing deaths, then that's what we should work on. And so we got each hospital is asked to kind of work on that. And so there's this AIM bundle that is specific for pregnant and postpartum people with substance use disorder safety bundle. All the bundles are divided into all these steps, like 4 R's, that talk really about education. So education is educating the prenatal offices of, this is the current state, what can we do about it? Educating the community of, this is happening in our hospital, and we really want to reduce the stigma and harm around substance use disorder, try to engage people in care early. Come to the hospital, we'll try to take care of you and your baby so that we can get the best outcome later on. Try to make sure that they are breastfeeding, because that's the best nutrition, and not avoid care because of fear and of being scared and just show up at the hospital still using substances and end up not being able to take care of their baby, not having education, and having DCYF being involved, and ultimately having someone else take home their baby, because that ends up worsening the situation for everyone and for all systems. So providing care that is very respectful and supportive. So that's ultimately is considered a harm reduction strategy. It's ideas aimed at reducing negative consequences associated with drug use. And these are appropriate throughout all of the life cycle, including pregnancy and prenatal, inpatient hospital, after the delivery, and for the newborn. So one of the action items that came out of that AIM bundle is to provide Narcan spray. So a few months ago, maybe in the summer, we started providing Narcan nasal spray to anyone who had identified a history of substance use or current substance use disorder. We actually, from the pharmacy, give them the nasal spray, and the nurses educate on how to use it. So that will the AIM statement is to decrease that overdose death. So in case somebody accidentally has an overdose, or if they don't use it, then they can provide it to someone who is in their community, in their parking lot, in their family. Anybody can use it. It's just to decrease that risk of death that's happening in our state. As of January, we're going to give it to every mom on discharge. That way we're not picking out, you might be somebody who appears to be using substances and you might not, and we're not going to put it in their medical record as, provided Narcan, so your, other doctor looks like, you have Narcan? It's just, here you go, take it, use it, put it in your bathroom. Maybe somebody else in your house might need it. Just having it available decreases the harm. So the other thing that we want to do is back way up, instead of finding this out at the other end like I did with my patients and those cases, is to screen early and often for, are you having any issues with substances? So at the OB intake, it's the very first visit with the prenatal nurse at all of our practices that come into Concord Hospital. And then we also ask in the third trimester of pregnancy, also at the hospital admission when they come in for labor and delivery, and again at the postpartum visit. Are you using any substances? Are you using alcohol? Are you using any prescription medications that are not prescribed to you, or any tobacco or nicotine? And if they are, providing intervention. Would you like to see somebody who is a counselor? Do you feel like you're addicted? Is there any way we can help you quit? And then education based on what they report for use. And then also assess medical conditions that might be associated with substance, like hepatitis, HIV, STIs, sexually transmitted diseases, and then treat those conditions as well. Also associated mental and behavioral health, because often substance uses are co-occurring with mental health conditions. And then also look at the social determinants of health that lead people to substance use disorder or mental health conditions that are all often are co-occurring, and how can we help provide resources to those conditions. So where do we get our numbers from is another of the AIM bundle. So our state has now required us on our birth certificates to document if the patient disclosed, or if they had any drug testing, if the baby was substance exposed, or if they demonstrated any outcome, any symptoms of withdrawal. And so that basically tells us what's the state of affairs across our state, and whether or not there was a federally mandated plan of safe care given back to the parents. So that's where these numbers came from that I told you. We now have in New Hampshire a 6.3% exposed rate of newborns. Was the infant monitored for effects of in utero substance exposure? In New Hampshire, 6.3%. And then was the infant identified as being affected by substance exposure? It's 1.4%. And then of those who were monitored, did the family go home with a written plan of safe care? And that's a document that the family takes home that says, if I were in trouble, who would I call? What are my resources? Who's my primary care doctor? Who's the pediatrician? Who's my OB? Who is my family support? When's my next appointment? Am I referred to early intervention services? All in a written plan of care that will help them be safe. And so the ones that are only, I shouldn't say only, but have been substance exposed, that number has 44%, and the ones who have been affected, they're in the hospital longer, they get more attention, and that one, they go home with that written care plan up to 85%. So these are things, all these things are things that we're actionably trying to improve the outcomes for. The Narcan, screening often in the prenatal course, and then documenting, and then this ultimately goes back to the state and to the federal government where hopefully we can get some more funding. So we have lots of community resources. Maybe some of you might be involved with some of these, but parents and families are referred to all of these areas. So we have the Doorway as a treatment program for medication-assisted treatment, primary care doctors like myself as a family doctor, legal assistance and transportation. And one of the biggest things is all babies that are substance exposed automatically qualify for early intervention services, which we try to encourage them to go through to ensure that they're developing appropriately in their first year of life or beyond. So really, my goal is that these are vulnerable babies and also families, and we want to coordinate our care, wrap around them at all stages as soon as they're identified into our healthcare system, and support them and be supportive in every way that we can to ultimately have the best outcome for them and for the rest of their lives. So I want to just thank you for listening. I know it's a little bit long. And then as you go forward, I hope that you will be supportive of families that have experienced substance use disorder and advocate for them and for their babies and for families. One of the sayings that I learned recently is a trauma-informed care language is not to ask when somebody has had addiction in their past, is not what, like what's wrong with you, like why did this happen, is to ask what happened to you. So if you can think that in the way that you think of this situation with those patients that I talked to you about in those cases, is starting the conversation in your mind or with them is that statement, what happened to you. It can change the story for you and for them, I think. So if you have any questions, I can stay for a few more minutes, but.
I've got a couple.
You're writing them down.
Do you automatically do a tox screen on every woman that comes in labor? And for these long stay babies or moms, how's the insurance coverage? Do you get cooperation from insurance?
Yep.
And do you see, another question, do you see any rise in your numbers, or is because there were fewer delivery sites in the state?
I'll go with the first one. We have no problem with insurance. As long as the baby has medical necessity, they stay in the hospital. And most women are covered with their prenatal care, no matter what. If they don't have insurance, then they qualify for Medicaid, as long as they can fill out the paperwork. And so sometimes we have to have social work help to get the paperwork all filled out to get coverage. The next question was, urine toxicology. No, so that screening that I talked about at the intake is verbal screening. Like, are you using any substances, tobacco, marijuana or THC? Do you have any history of substance use? Are you currently using any substances? And if they say that they are, then we ask, are you willing to document with a urine toxicology screen? If they say that they will, we consent them, and then we document in the medical record that they're willing to provide a sample. And then if they're not, we can't take it from them. If the baby then has symptoms, we can. We are actually, as the physicians, medically in charge to do the right thing for the baby, and we can take a sample from the baby, but not the mother. We can take a urine sample from the baby, and we can take an umbilical cord sample from the baby without the mother's consent for medical necessity, because at that point it's a situation of abuse or neglect from the state, and as physicians we're essentially in charge. So that's part of the conversation way back at the beginning when we're asking them the screening questions. It's much better for you if we have this conversation and educate you now, because if you're using anything, we want to get you help and get you in care and with counselors, and if you need any medication to help you stop using, we want you to stop. You have 9 months of pregnancy. We want you to stop using now if possible. If you're on a medication that you need to remain on, we'll get you on a medication to maintain sobriety on the medication so that when you come in the hospital, everything's fine. You'll be able to breastfeed, your baby won't go through as much withdrawal, and as according to the state's eyes, you're doing everything that you need to do, and you'll be stable and you'll be able to go home with your baby and everything will be as good as possible. It's probably non-disclosed name versus the number of, we have statisticians that are taking the numbers off from, because we just have, like that graph that I showed you was like the number of births per year, per month in our hospital, and I think that all just goes to the state of.
I just have a comment. When we began to put together proposals, grant proposals to help fund some of the work that they were doing at the family place, one of the taglines that we used to use was, let's give the mom and baby the best chance we can at this window of opportunity. So both the mom and the parent, if they want to do the right thing, and this is their window of opportunity. If we can gain their trust, if we can educate them at that time, that's a great opportunity to affect change, like you said, So that window of opportunity is vital.
Yeah, I'm just going to repeat that in case you're recording that. Deanne just said that when we're asking for any grants, the pregnancy is a window of opportunity, because if there's going to be a moment in a family's life that they are most vulnerable and open to change, pregnancy might be it. And I think that was actually, just to wrap this up, I think that was actually the key piece for me when I was like a young adolescent and reading that story. I thought, who wouldn't want to help women who are pregnant? And if these women are using crack cocaine way back in the 90s, and I didn't know anything about pregnancy, I thought everybody wants to help a pregnant mom, and the mom wants to help herself, and she has a whole future ahead of her, and her family and her baby. And I'm like, that's what I'm gonna do. I'm gonna be a mom and baby doctor. And when I went to medical school, that's when I realized that's not actually a thing. You can be an OBGYN, or you can be a pediatrician, or you could be a family doctor. And that's what I did. I became a family doctor, and now I did a fellowship in obstetrics, and now I actually mostly I educate the residents on their OB care and their nursery care, and every day I do moms and babies, and I now have to go take care of a mom and a baby, because that's what I ended up doing, like way back when I was like 13 years old, because that's the best opportunity of changing our future generation's life, is to get in that window of opportunity. So thank you.
Well, we'd like to thank that biology teacher for sure for instilling that in you in that article. Thank you for joining us today. Thank you so much for being here as well, Dr. Yerdon. Our next What's Up Doc presentation will be on Friday, January 12th, and I believe it will be on primary care. There'll be more that we'll announce soon. So thanks for coming. Have a great holiday. Be happy and be safe.